You hear us, Silvia? Just say hello. Or maybe let's try David Perry. Good afternoon, David Perry. Are you able to hear us? Welcome and for joining us on this platform. Dr. Christopher Mzungairi, good afternoon.
Good afternoon, sir.
Thank you. Great that you've been able to join us. Thank you. All right, so I think we can start our session now. And I hope we've been able to see some of the meeting etiquette that's been displayed for us here. And we want to make sure that everybody is participating actively and that they're able to get around the Zoom platform so that when they want to speak, they know how to get around with that. So thank you very much for that. So today, we'll be discussing an issue on U equal to U. And so I'll just ask IT to just drop this and then be able to share the slides. So we also have been joined by our panel experts. And today we will have Dr. Bupe Musonda as one of the panel experts. We also have Lina Mwango as a panel of experts just to take us through some of the discussions as we continue to venture in. Then we also have 3 cases for today. And so we'll have 3 breakout sessions. And so we'll have the Lusaka, Southern and Western province. And so I'll invite them to just prepare themselves. As soon as the didactic ends with a few questions, then we'll transition to the breakout sessions, and then we'll have those cases being presented. Very interesting cases of U equal to U, and some very interesting questions that have been raised there. So this being said, I will just introduce our didactic presenter today. It's Dr. Natalie Vlahakis, and just invite her to say hello to the team. Dr. Vlahakis.
Thank you very much, Dr. Zyambo. Good afternoon, network. Happy to be here today presenting to the network on U equals U. As I've been introduced, I'm Dr. Natalie Vlahakis Mateta. I work with CIDES as their prevention lead and also specialist in community interventions, and so play a dual role there. The objective of the session today is just discussing a little bit around U equals U. Where are we now? And also, what are the public health implications of U equals U? And discussion on the discontinuation criteria for PrEP clients with suppressed partners. So those are the main focus areas, but a little bit more information as well will be shared during the session. So maybe a little bit of feedback from yourselves to start off with. If there's anyone on the network who can share with us what we think about U equals U. When we talk about U equals U, what is it that actually comes to mind? And then the second question is, in your practice, have we ever been faced with a discordant couple that wishes to ensure that the HIV negative partner remains negative? And what is it that we advised our client? Anyone from the network?
So please do raise your hand, and then we can unmute you so that you can just share experiences out there. I think this is a platform for sharing best experiences and some of the work that we're doing in our provinces. So please raise your hand, and then if you can just speak. So I know that there's a lot of feedback on people when they hear you equal to you, and there's a lot of stories out there. So maybe we want to hear it from you. What do you think? What really comes to your mind?
And it's an opportunity to just share, to see what is it that's happening in practice, what has our experience been. I know for many of us on the forum, I think we had U=U campaigns in our provinces a couple of years back. So any volunteers to start the discussion? Thank you.
I know there's Dr. Onoya on the call, and I know he works in an environment where we've got very interesting thoughts around this. Dr. Onoya, you want to make a comment to that?
Yes, Dr. Zyambo and Dr. Natalie, good afternoon.
Good afternoon,
Good
thank
afternoon.
you.
I'm sorry, I just want to be sure that I've well gotten the question. Kindly repeat it, please, Dr. Natalie.
So have you, when you think of U=U, what is it that comes to mind? And in your practice, have you ever been faced with a discordant couple that would like their HIV negative partner to maintain negative?
Yes, Dr. Natalie, thank you so much. So it's happening almost every day. And when we know that the ultimate goal of ART is to have the client virally suppressed. And we know that it has been proven that those who are virally suppressed, they can no longer transmit the virus to their sexual partners, not only the sexual partners, but even the child in case of pregnant women. So I know that those who are HIV, our clients who are living in a discordant couple, for sure, there's no one who wants to infect others. All of them, I can say all of them, they want their sexual partners to remain negative. And that's the reason why there are different interventions put in place, like PrEP. And we always propose PrEP to the client so that they can remain, the sexual partners can remain negative. But also we know when they are, the one who is HIV infected, when is virally suppressed, I think it's contributing to the non-transmission of HIV to the other sexual partner. Thank you.
Thank you very much, Dr. Naya. I think you've given a very good introduction to the session that we are going to have today. You have summarized it well, and clearly in our facilities, we are faced with this kind of client on a day-to-day basis. So we'll now move into the presentation itself and take it from there. So when we talk about the U=U, everybody always remembers it by the U=U campaign. And just to mention that internationally, the U=U campaign is a campaign that raises the awareness of the benefits of ART across different countries. Currently, there are about 720 organizations around the world in 90 countries that have joined this U=U campaign. And this is largely a message which is being passed on the importance on maintaining viral suppression so that as many people as possible that are on ARVs can be undetectable. So when we look at what has happened within Zambia, the U=U campaign in Zambia, well, it started, I would say, in 2018. But in 2018 itself, the beginning of 2018, Lusaka was named as one of the 15 fast-track countries, or cities, sorry, in ending AIDS by 2030. and recognizing the important role that these cities play to be able to achieve national as well as global, the global HIV targets. This project was set up by UNAIDS. But the Zambian government took it a step further. So in 2018, in December, the U=U campaign was launched by the President of the Republic of Zambia. And from there, it trickled down to multiple campaigns across the country. And these were what were known as the surge campaigns. In 2018 as well, the Ministry of Health adopts treatment as prevention within the guidelines. And in 2018, NAC took the lead in the process to ensure that we have a national PrEP implementation framework. All this is in line with achieving U=U. So what is U=U? When we talk about U=U, it's undetectable equals untransmittable. It means that someone with an undetectable viral load on ART cannot transmit HIV. Next slide. So we have key terms and definitions. Viral load is a measure of the amount of HIV in the body. Viral suppression is when ART is taken long enough to reduce the ability of the virus to make copies of itself in someone's body. Undetectable viral load, when someone is on ART and the virus level in the body is so low that standard blood tests are not able to detect the virus. And untransmittable basically means HIV cannot be transmitted through sexual transmission when the viral load is below 200 copies per mil. We talk about what does U=U involve. So when we talk about what U=U involves, this protection from ART depends on taking ART every day, having undetectable viral load for at least 6 months, continuing to take medication on a daily basis. So those are very key in terms of ensuring U=U.
Wanted to see some poll questions.
We can take the first one.
Okay. So the network, I think at this stage we'll do some poll questions, and then for us just to see what really are we trying to say here. And so the first question here says, which of the following definitions is correct? Which of the following definitions is correct? Viral load is a measure of amount of HIV in the blood, in the body. Viral suppression is when ART is taken long enough. Undetectable viral load is when someone is on ART, and undetectable is someone's on ART and the virus levels in their body is low, so that they, sorry, this is incomplete. And D, untransmittable, refers to when HIV cannot be transmitted through sexual transmission, or all of the above definitions are accurate. So kindly select which answer here is correct. Okay, so which of the following definitions is correct? Viral load is a measure of amount of HIV in the body. Viral suppression is when ART is taken long enough to reduce the ability of the virus to make copies of itself in someone's body. Undetectable viral load is when someone is on ART and the virus level in their body is so low that standard blood tests cannot detect it. Transmittable refers to when HIV cannot be transmitted through sexual transmission when the viral load is below 100 copies per mil. All of the above definitions are correct. Okay, so I think I'll end the poll for now, and then we can discuss as we continue. I'll hand over back to, sorry, let me just see how we're doing. So most people think E is the correct answer. Okay, so we can pick it up, Dr. Vlahakis.
Okay, that's great. So when we talk about undetectable equals untransmittable, we look at our graph. Within the first 6 months, we become undetectable after starting treatment. That is the period when an individual is most at risk of transmitting the virus. After 6 months, most individuals that have been adherent will be undetectable. So they stay undetectable after the first 6 months, and then they cannot pass HIV through sex as long as they stay undetectable. They take their medication daily, and they see their healthcare provider on a regular basis. So no missing of the appointments, ensuring that they always have their drugs available. When we talk about how do we know U equals U is so effective, there have been researchers that have known this for over 20 years, that ART reduces transmission risk, but it is only recently that the zero risk has been proved. Through studies, many to mention, but largely the partner studies. These included couples where one partner was HIV positive on ART and the other partners were HIV negative. And it also, through the study, they had to make sure that whilst being enrolled on the study, they were not allowed to use condoms, just to make sure that they are sure of whether ART does provide that benefit of undetectable equals untransmissible. So this is just to showcase a few of the studies, and the partner study has been ongoing for many years. And it was not until the fourth partner study that we really begin to see a bit of change in the way we implement, the findings. So using treatment as prevention, that is a very good way to be able to prevent others from acquiring HIV. Next slide, please. So how long does the virus need to be undetectable? As we all know, within our national guidelines and many other guidelines, having an undetectable viral load, we normally wait until 6 months before relying on 100% protection from U equals U. So this approach is cautious because it depends on the various ARVs as well, or that a country has adopted. And also it's to make sure that an individual is really adherent on treatment. How can we know whether there is risk? So when HIV viral load is undetectable, there is too little virus within the fluids for us to be able to contract HIV sexually. So any risk of sexual HIV transmission relates to viral load that is being undetectable and reduces the risk to almost zero. But as we know, for Zambia, any prevention intervention has to be a combination prevention intervention. And I stress here the importance of ensuring that even though our clients and recipients of care are undetectable, we encourage the dual use of ART as well as condoms. Next slide, please. We now come to the question whether PrEP can help U equals U. So we know that PrEP is a medication that uses a combination of drugs to keep HIV from reproducing and growing within the body. And PrEP and PEP use ARVs in their action against HIV acquisition. So we have to make sure that how we know the difference between PrEP, which contains 2 drugs, and that these 2 drugs are meant to be used prior to HIV exposure or during the seasons of risk, whilst PEP uses 3 drugs, so full ART, and it can be given following HIV exposure for a period of 28 days, but within 72 hours of the exposure. Having an HIV negative client on PrEP can help an HIV positive client, who is their partner, on full ART to remain adherent. So as a support buddy, they support each other to make sure they're taking the drugs, and this helps maintain U equals U. So if it's okay, we can move to the next poll question.
Sure, thank you. The next poll question, here we're still talking about U equal to U. Which statements about U equal to U is the most complete? To achieve U equal to U, the recipients of care must ensure good adherence to ART. Having an undetectable viral load at 6 months, a good consistent supply of ART and PrEP drug is needed. Then recipients of care must maintain good adherence, viral suppression for at least 6 months, have consistent supply of ART and access to viral load monitoring. Which statements about U equal to U is most complete? A, to achieve U equal to U, the recipient of care must ensure good adherence at ART. B, having an undetectable viral load at 6 months. C, a good consistent supply of ART and PrEP drugs is needed. D, recipients of care must maintain good adherence, viral suppression for at least 6 months, have a consistent supply of ART and access to viral load monitoring. So kindly pick which one you think is actually a complete statement. So far we have people that have managed to poll, and about 50% of those that are participating in this meeting have managed to poll. Okay, so I think I'll give you a bit more time to complete the polling. Okay, thank you very much, everybody, for taking part. Let me just share the results. Okay, so most people think D is correct. A few thought A was correct. Let's see how this goes. Thank you so much. Back to you, Dr. Vlahakis.
Thank you very much, Dr. Zyambo. Next slide, please. So how well do U equals U? So undetectable equals untransmissible and PrEP work. We know that for many different, many different subpopulations, U equals U has been quite beneficial to both heterosexual as well as to key populations. We do know, though, that it is important for daily use of PrEP for us to be able to ensure that the risk of acquiring HIV is reduced. Next slide, please. How well do U equals U and PrEP work? So U equals U is 100% effective against preventing HIV transmission while PrEP reduces the risk of acquiring the virus by 99%. And here we talk of oral PrEP. The effectiveness of oral PrEP is highly dependent on adherence. With maximum adherence, we increase effectiveness, and taking PrEP daily will ensure that, and consistently will ensure that it improves U equals U as well. Next slide, please. So there are a few questions, and one of the main ones that is asked is, if my partner is undetectable, should I take PrEP? So when can a client in a discordant relationship discontinue PrEP? Here we need to ensure that first we guarantee continuous viral load suppression, that we have no viral blips, that no challenges with adherence at any time. We have to make sure that we have a valid viral load result on file, that a client is able to be bled on time and receive their results timely, and results returning to the facility are entered into SmartCare. We have to ensure that the client has no other sexual partners and also no STIs. So when we talk about pregnant and breastfeeding women in a discordant relationship, these have to maintain on PrEP, and PrEP should not be discontinued, regardless of whether they tick all the boxes above. Next slide, please. So with PrEP, it is important that we ensure good adherence support for it to be highly effective. We have to also ensure that it maintains the same for their HIV positive partner that is on ART. They too need good adherence. We have to ensure that they have no other sexual encounters until after 7 days for men and 21 days for women. And we must make sure that we continue this, the long exposure. If it persists, they have to maintain on PrEP. We have to give client-centered counseling, ensure that we're listening to the client and making it easy for them to take PrEP. And they are enrolled into special programs that may offer them support. Also, it is important to know that the side effects that come with PrEP are self-limiting. So normally they will feel a few side effects in the beginning, such as nausea, abdominal pain, and headache, but these soon disappear, and clients should be encouraged not to stop PrEP immediately. Next slide, please. So when do we stop PrEP? So PrEP can be discontinued if an individual taking PrEP is no longer at risk and when their situation changes. So for example, they were in a discordant relationship, but they've had a divorce, so they're on permanent separation and they're no longer at risk. Or when they're no longer at risk or at any high, risky behavior, so they're out of a season of risk. PrEP can also be discontinued only after 4 weeks of being on the PrEP drugs. So encourage the client to say they take it continuously for 28 days after their last exposure. Significant side effects, for example, creatinine clearance, that is less than 50 mils per minute. For those on PrEP, they need to be, stopped off PrEP. And then if we have a serodiscordant relationship where the HIV positive partner has been on ART for more than 6 months, is known to be virally suppressed, has no other additional partners, and the HIV negative partner is on PrEP, has been on PrEP, they may consider stopping PrEP, but then always maintaining that they use condoms. And then for, as mentioned earlier, for pregnant and breastfeeding women, we do not encourage that we stop PrEP. Next slide, please. So within the guidelines, and this is directly out of the guidelines, it highlights a few key areas or special situations. So for example, PrEP does not affect the efficiency of hormonal contraceptives. And so we maintain PrEP if they need to be on PrEP. We've spoken about the pregnant and breastfeeding women. For those who have hepatitis B, the hepatitis B vaccination is appropriate for those at substantial risk of Hep B infection and HIV, and also management of HIV exposure with PEP. So ensuring that those that were exposed to HIV receive PEP within 72 hours from the exposure and maintain on a PEP for 28 days. Next slide, please. So here again, it's just to highlight that although an undetectable viral load on ART also reduces the risk from breastfeeding, it doesn't reduce the risk to zero. So even through the study phases, they did find that in pregnant and breastfeeding women, there was always a small risk that was maintained. And hence the importance of ensuring that mothers maintain on full ART, and in discordant couples, the HIV negative pregnant and breastfeeding woman also maintains on PrEP. Next slide, please. So we have a few programmatic considerations that are important. So ensuring that we have, or HIV programs have a consistent supply and easy access to HIV treatment. And depending on the combination of the drugs, maintaining at least 6 months with viral suppression before they can be, clients can be considered untransmissible. So viral load tests must have clear guidance on the frequency to get tested, and also testing must be made easily accessible. And through the Ministry of Health, we know that within our provinces, we do have viral load testing. For the viral load that may become undetectable in people living with HIV, if they are not adherent, you will find that this changes. So ensuring we provide that support for our recipients of care to be adherent is very important. For people living with HIV with a suppressed viral load, they can't transmit through sexual transmission. But then it is important to still remain protected. And within Zambia, we encourage utilizing condoms as well. So dual methods of prevention, basically, combined prevention interventions. U equals U doesn't mean that an individual living with HIV is cured of HIV, but just that they are undetectable. And that message needs to go out clearly to the recipients of care, because as soon as they stop treatment, it means that the viral load will increase. So some people experience what we call a transient viral increase, or the blips. So after the blip, viral load returns quickly to normal or to undetectable without any change in therapy. So most times these blips are small, between 50 to 1,000 copies. But as mentioned earlier, combination prevention intervention. So making sure that we encourage our clients to still continue using condoms. Next slide, please. So this is a slide that just showcases some of the important things we need to consider within our programs targeted at key populations. So making sure that we incorporate messaging of U equals U into the key population groups as well. ensuring that we update the staff as well as all implementing partners on U equals U and discuss implications of that in KP programming. We need to work with the local partners to make sure that all channels of communication, the U equals U message is clear, really stressing on that point that, you know, it does not cure you of HIV, but you remain untransmissible as long as you maintain adherent on treatment. Training community-based staff as well as healthcare workers on the importance of the U equals U message, incorporating this messaging into relevant community outreach programs, into our DSD models for KP delivery, and advocating with national stakeholders for the multi-month dispensation of ART, which here in Zambia, it is policy, but making sure that we implement that policy on the ground is also key. Next slide, please. So just to stress that U equals U should not be recommended. Currently, we don't have enough information, you know, and the results that came out did not have enough information to say that suppressed HIV viral load will prevent HIV from being transmitted in individuals that are injectable drug users. And then also stressing that it is important to make sure that for pregnant and breastfeeding women, regardless of whether they are undetectable, it's important that they maintain with all prevention interventions. Next slide, please. So we now move to some of the frequently asked questions. Does U equals U work with all HIV drugs? The answer is yes. So any ART that makes viral load undetectable will mean it supports U equals U. Does U equals U work for everyone? The answer again is yes. So both for KPs, both for heterosexual couples, you know, U equals U has shown that it can work. So as long as they maintain undetectable, they will be untransmissible. Does U equals U work regardless of the type of sex that partners are engaging in? So the partner study did show that, you know, regardless of the type of sex, that it was safe as long as they are able to maintain adherent on treatment. And does it mean that I can stop using condoms? This is the big question. And within the Zambian guidelines, it is very clear that we have to continue using condoms, that it should be a mutual choice with the partner, but ensuring that condom use is there. They will reduce many STIs and they will increase also the efficiency of the prevention intervention that is being provided. What if I miss my medication? So it's important to know that missing medications once won't change the U equals U status, but missing 2-3 days in a row, then yes, a risk begins to play. So adherence is really important. STIs, do they affect U equals U? So based on the study, they don't, but it is important to stress that here we have to prevent STIs because STIs might put other individuals at an increased risk. Making sure that for the viral blips as well, that if they're below 200, it's not so, you know, U equals U is still maintained, but then, you know, how sure will we be whether it's 200, 800? So it's important always to use combination prevention, at least encourage our recipients of care, our PrEP clients, discordant couples to be on PrEP, ART, where it's needed. Next slide, please. So in summary, we talk of the key points. So undetectable equals untransmissible. This means that someone with an undetectable viral load on ART cannot transmit HIV. And through the study, they showed that this was even using condoms and PrEP, but you know that with a study, it's a very controlled environment. Here within Zambia, we encourage utilizing combination prevention interventions. So PrEP can keep a person undetectable by ensuring that they cannot contract HIV in the first place. So even if they are exposed, and it is important that guidelines recommended having an undetectable viral load for 6 months before we can rely on 100% protection from U equals U. And our treatment programs need to ensure that we're having a continuous supply and improved access to HIV treatment. Next. So this is just a list, and I'm sure the presentation will be shared, of various videos that showcase easy messaging on how we can transmit some of the information or answer the questions that are brought forth from the clients. And a video done by BFlow, which was used during the initial campaign in Lusaka. Thank you.
Thank you so much, Dr. Natalie, for this great presentation. Lots of exciting points that have come out. And I do hope the network has got some questions they want to answer, so they can raise their hands and then we can just refer to them. But for now, we would like to just redo the poll questions so that we see how you can just run us through some of the answers. Dear network, I have posted a poll question. Poll question number 1, please do make your poll again, what you think. So which of the following definitions is correct? Viral load is a measure of amount of HIV in the body. Viral suppression is when ART is taken long enough to reduce the ability of the virus to make copies of itself in somebody's body, and that is less than 1,000 copies per mil. Then the C, undetectable viral load is when someone is on ART and the virus level in their body is so low that standard blood tests cannot detect it. D, untransmittable refers to when HIV cannot be transmitted through sexual transmission when the viral load is below 200 copies per mil. Then E, allow all the above definitions are correct. Dr. Vlahakis, what do you think? This is how most people think it's E. So you could run us through this?
Most people think it's E, and they are correct. So all the statements above are correct about U equals U. So we have to have a viral load. If we could just go back. So viral load is, the definitions, that have been posted are correct. So viral load is the measure of the amount of HIV in the body. Viral suppression is when ART is taken long enough to reduce the ability of the virus to make more copies. And undetectable viral load is when someone is on ART and the viral level in the body is so low that it cannot be detected. Untransmittable refers to when HIV cannot be transmitted through sexual transmission when the viral load is less than 200 copies per mil. And so all the above are correct definitions.
Thank you so much. Second poll question. The network, you can try your answers once more. See if you're doing better now after going through the whole presentation. So in this particular poll, we want to find out which statement about U equal to U is most complete. We've got statement A, to achieve U equal to U, recipients of care must ensure good adherence to ART. B, having an undetectable viral load at 6 months. C, a good consistent supply of ART and PrEP drugs is needed. D, recipients of care must maintain good adherence, viral suppression for at least 6 months, have a constant supply of ART and access to viral load monitoring. So this so far are the statements. I'll end the poll, sorry, and just ask Dr. Vlahakis to run us through this particular poll questions. Most people think D is correct.
No, thank you very much, Dr. Zyambo. And I think the network has really grasped the essence of the message. D is the correct answer. So recipients of care must maintain in good adherence. They must be virally suppressed for at least 6 months. They must have consistent supply of their ART and access to viral load monitoring. That is the only way that we would be able to ensure that we have U equals U, so undetectable equals untransmissible.
Thank you
very much.
Thank you very much, Dr. Vlahakis, and I do hope the network has had a very informative session so far. I have a hand from Maureen. So Maureen, kindly unmute yourself, and then you can go ahead and ask your question or clarification.
Hello.
Hello, Maureen.
Okay, this is Maureen. Am I audible?
Yes, we can hear you.
Okay, so I wanted to ask, U is equal to U, does it only apply to sexual transmission?
Thank you so much for your question. We'll respond to it. I want to give a chance to Imanga Sinyinda. Go ahead and unmute yourself. Imanga.
Good afternoon. I want to find out, I heard you were talking about pregnant women in breastfeeding.
Please go ahead.
Whenever they had needs. Is it a mandatory for pregnant mothers or those breastfeeding mothers to PrEP when they have this?
Okay, so we struggled a bit, Imanga, to hear you. I'm not sure about the network, how it is, but maybe you could just type in the chat. But I think Dr. Natalie will try and respond to that one. You want to find out if it's mandatory for pregnant women to always be able to take these PrEP drugs. So one final question from Jackson Mwewa. Please unmute yourself, and then you can speak. Jackson Mwewa, go ahead.
Yes, good afternoon.
Afternoon, thank you for joining us.
Yes, I think I just have two questions.
Go ahead.
So my first is, should we stop PrEP in discordant couples once the partner become undetectable? If yes, at how many months? Then another thing, I wanted a clarification over the untransmissible. Is it when the viral copies goes beyond 20 copies or below 200? I need a clarification. Thank you.
Thank you very much. Very, very interesting questions. Thank you for asking those. Before I get back to the chat, maybe I'll allow Dr. Vlahakis to respond. But I'm aware that we also have some experts on the call who may also want to chime in. They can feel free to just raise their hand and then they can make a comment. Dr. Natalie.
Okay, so maybe we have a couple of questions. So the first question was U equals U. Does it only apply to sexual transmission? So, the answer to that would be, yes, because with U equals U, the sexual transmission is the only one that they really saw an improved benefit. So for example, for those that are injectable drug users, the benefit was, there was still a risk. So important to make sure that we maintain those on PrEP or on, partners on PrEP and the others who are HIV negative on, HIV positive on treatment, and they are discordant couples who are HIV negative on PrEP. And then for the pregnant and breastfeeding women, there was still that risk of transmission to the child. And hence why it's important that if a woman is pregnant and breastfeeding, we maintain them on PrEP. That way, it would help also, can I say, to increase the benefit or make sure that there's actually no transmission. So for those two groups, it's not necessarily sexual, and we have to make sure that if it's a pregnant and breastfeeding woman in a discordant relationship, make sure that she is on PrEP and her partner is consistent on and adherent on his ART. So, and the third question and the fourth question, maybe I'll throw to the panel of experts on the call. Third question was, should we stop discordant partners when they become undetectable? And when we talk about undetectable, is it less than 20 copies or less than 200 copies in the context of Zambia? Thank you.
So thank you. We would like to hear from any of our experts on the call. I know we have Dr. Musonda, I've got Lina, Mwango, and then we also have Dr. Mwamba. I don't know whether Dr. Okuku is on the call as well. Any comments from the experts on the call?
Okay. So I could still take it up and they can chime in as we go.
Sure.
So for discordant couples, once in a discordant relationship, the partner is virally suppressed, maintained viral suppression for 6 months. They're adherent on their treatment, and the couple feels they would like to stop PrEP. It is safe enough to stop, but it's important to note that couples, discordant couples, for the recipient of care who is on ART, it is an increased benefit when their partner is on PrEP because they support each other. And so they make sure that adherence is improved for both of them. And then the last question about undetectable being, is it less than 20 copies or less than 200 copies? I think for undetectable, it varies from country to country. It varies with the machine that we are using in country. But you are virally suppressed if your viral load is less than 1,000 copies, and you are undetectable in the context, and even within Zambia, I think it depends on the machine that is being used. We have some where it's less than 20 copies, and others it will just state that the result comes back as undetectable. So it varies from one lab to another, depending on the equipment that is being used. I'm happy for any others to come in or chime in with any additions. I see a hand.
So I've seen Dr. Nindi, you can unmute yourself and comment, and then we hear from Dr. Daniel Mwamba.
Thank you so much. Good afternoon, Network, and good afternoon, Dr. Natalie and Dr. Zyambo.
Good afternoon.
Mine, I just wanted to just add a comment over the nice explanation you gave for discordant couples. I think sometimes also, I think using, depending, especially for new clients, you may also consider keeping track for a little bit longer if you are not very sure if your partner is going to be adherent throughout. So you know that the longer the client stays on treatment and they develop the habit of taking medication, the chances that they are going to remain virally suppressed are going to be very high, therefore increasing the confidence that your partner is really virally suppressed, and the U equals to U can come into effect. Thank you.
Thank you very much, Dr. Nindi. Dr. Mwamba.
Thank you, Dr. Zyambo, and thank you, Natalie, for the presentation. The last question, which asked about the threshold for undetectable, referring to 200. I believe it because there's a 200 copies mentioned in the slide. So of course we know, as Natalie has explained, it's dependent on which machine is being used. Level of undetection varies. But for the studies that were that brought evidence to the U equals U, that study had used 200 copy as the threshold, and what was found that anything below 200 was equal to zero transmission. But in our setup, that depends on which machine we are using. They're below 50, below 60, and below 20, depending on the machine we use. So the 200, yes, it was just for the study the purpose of the study that we conducted. Thank you.
Thank you so much, Dr. Mwamba, for that clarification. So in view of a limited time remaining with, I would like to invite the Western Province team, the Southern Province team, as well as the Lusaka Province team to be able to start preparing themselves to move. So we're going to have a breakout session. And then we'll go into breakout rooms according to those provinces. And so just ask IT. I hope Southern, you're ready. And so we know that Dr. Mwamba and Lina Mwango, you'll be in the Western Province team. And then Dr. Bupe Musonda, you'll be in the Southern Province team. And then Dr. Natalie will be in the Lusaka Province team. So these are the directions on how you're going to do it, going to your breakout session. So the host will start the breakout session soon. Then you need to click to join the breakout room icon, which has 4 squares. And then you choose the breakout room you wish to join. And so you pick either Southern, Eastern, or Western. And then you pick, in this case, you have Southern, Western, and Lusaka. Eastern won't be present. So once you do that, then you can join in. And so I would like to make sure that our province coordinators, please quickly join in onto your rooms, go to your breakout rooms, and then you can select which room. Are we ready, IT? Okay, so we'll see you in the last 5 minutes of the closure, then
We'll start sharing soon.
Dr. Safole, yes, we are ready, but it's like the gadget we're using, network is dropping us.
So can I share on my end?
If you have it, yes, you can. Thank you.
All right, thank you.
So good afternoon. Jane will take us through.
So good afternoon, network.
Care was diagnosed on the 10th of March, 2014, and was commenced on here on the 7th of July. The instance of care never met anything of permanent
Good afternoon, network. So my name is Jean Hamakwa, Clinical Officer General from Mahatma Gandhi Clinic. Okay.
Good afternoon. Hello, network. Are you able to hear us?
Yes.
Yes, we are. Okay, thank you. So good afternoon, network, once again. My name is Jean Hamakwa, Clinical Officer from Mahatma Gandhi Clinic. So I'm here to present a case in line with you equals you, with the help of my co-presenter, Mr. Evans Kabala. So in here, we came up with a scenario as a facilitator. Our croc goes by the name of HS, female 38, RVDR. We were presented on the 19th of January 2021 with a cough, screened positive after using the HIV screening tool. And of course, the results were reactive. The ROC wasn't initiated on the very day due to the TB investigation because she came up with a cough. But 2 weeks later, was seen with the husband and started on ART. That was TLD, and we initiated isoniazid, vitamin B6, and also septrin was added after TB was ruled out. The husband was tested for HIV, which was NR, and was started on PrEP the very first day. That was on the 7th February 2021. But PrEP was later stopped on the 5th August 2021 after the wife had a suppressed viral load. On medical history, no known medical conditions, and on drug history, amoxicillin and paracetamol was given together with TLD, isoniazid, vitamin B6, and septrin. No known drug allergies. Socioeconomic history, of course, she's married with 3 children who are all in RVD-NR. She's a grade 7 and stay at home as a housewife. On physical examination, the current vitals we took, it showed general conditions stable, no pallor, jaundice, no cyanosis, available to touch. On vitals, temperature was 36.9, BP 125/82, pulse 98, respiration, it was 22, weight 60 kgs, and height 155 centimeters. Systemic examination, it was okay. Okay, next page, yes, thank you. On investigations, on the 19th, when the rope came through, when the rope came through OPD, of course, we tested that. The results came out reactive, and we did gene experts to rule out TB, and it was undetectable. So the rope was given amoxicillin and paracetamol. On the 7th February on initiation, we did chemistry, HB, and viral baseline was done. ALT was done, it was 22.8, creatinine 62.9, HB 12.2 grams per deciliter. And the regimen, TLD, isoniazid, vitamin B6, and septrin was given. The client came back on the 4th of June, which we repeated the viral load, and the results were TND, 0 copies. The results came out on the 21st June 2021. On 5th August 2021, the husband stopped PrEP, but we did again the HIV test, which was NR. On the 10th of March 2022, we had no CD4 count reagents, no chemistries. We only managed to do HB, which was 4.8 grams per deciliter, and viral load copies was done. It was TND. On the same day, the husband came through for testing as well. We did another test, which came out NR. Next page, please. Our questions at the facility we came up with. Number one, how do we continue managing this woman to ensure she doesn't transmit HIV to the husband? The second one is, what other parameters should have been used to stop PrEP in the husband other than the wife's viral load separation? And the last one was, how do we follow up the husband to ensure that he doesn't seroconvert? Thank you so much. I submit.
Oh, thank you very much, Mahatma Gandhi. Thank you very much, Rita, for that good presentation. It's a good case. I hope we can quite learn a lot from the case that Mahatma Gandhi has presented. So network, the case has been presented to us. I just call upon us to feel free and discuss this case, because the facility would need some feedback from the team. Just to summarize the case, so Mahatma Gandhi had a female 38 who tested HIV positive and was initiated on ART, specifically TLD. 2 weeks later, the husband came and also was tested, and the results came out negative for HIV, and he was put on PrEP. 6 months down the line, when they did the VL, the wife, who is the client, the VL was undetectable, target undetectable, and the husband was then stopped PrEP. 6 months, VL not detected, and the husband was stopped PrEP. On physical examination, it was unremarkable. Liver function test, creatinine and HB were all within the normal range. And from the results, we see that the 2 VLs that were done for the client were all 0 copies. So the team is now wanting to get some answers to what could have been done. But before we go there, do we have any clarification based on what has been presented to us? Anything that you think the facility might have missed, or any clarification on the case and how it was managed? Feel free, please, to come through. You can just use, you can just raise your hand and we'll be able to allow you to speak. Any clarification? Or are we saying that the case was so clear that we have no any clarification? Okay. Maybe just, I have one question to the facility. We see that the husband came with the wife later, and the husband was put on PrEP. As we have seen from the presentation, we see that putting the husband on PrEP is a good thing, but was adequate counseling done for the husband so that he understood why he was put on PrEP and for all this duration? Mahatma Gandhi, you can come through.
Good afternoon, network. My name is Kavala Evans. Yeah, it's just that the presentation has to be in a summary form. But if we were to put in the nitty-gritties, that has to, it would have shown that when the husband came, we actually canceled this husband thoroughly. And it showed after, when we were just about to stop this client, it showed that the husband actually was helping very much, like it was presented in the presentation by the doc. He actually helped very much in the adherence of treatment to the partner who is actually HIV positive. So it was done, and it wasn't done just once. It has continued even the time that we stopped giving PrEP up to now. Even the last time we met on the 10th, we had to cancel on the importance of continuing supporting the partner who is still on ART treatment, so that she keeps on undetectable viral load. Thank you. I submit.
All right, thank you very much. Any question, any clarification on the case before we respond to the question that the facilitator has given us? Please, you can just come through if there's any comment or any question. All right. Okay, we'll go to the questions that have been given. Thank you for the case. It seems the case is clear that all the necessary things are done. So we will start first by giving a chance to the network before we call upon the experts to give some response to the question. So the first question is, how do we continue managing this woman to ensure that she does not transmit HIV to the husband? Any response to that? How do you think this woman should be managed to ensure that she does not transmit to the husband?
Chair.
Yes, you can come through.
So I think of importance to me is the issue of adherence. To me, that is what is of importance. And then it will also be important that after 6 months or so, we should be able to follow, we should be able to do a repeat of a viral load so that we can still see that if the client is still suppressed or not. Of course, ongoing counseling is also important to them as a couple. Thank you.
All right, thank you very much for that good submission. The issue of adherence is coming out there. Any other person to give an attempt to this question? How can we help? Yes, you can come through. I had some feedback. Okay. Maybe we go to the next question. What other parameters should have been used to stop PrEP in the husband other than the wife's viral suppression? So we see this is a husband that was stopped after 6 months of seeing that the husband and the wife was suppressed for 6 months and was stopped. What other intervention? Okay, due to time, we'll go to our experts. I'll call upon Dr. Bupe to please give the feedback to the first question. Doc, can come through and help us. How do we continue managing this woman?
Good afternoon. So, I mean, apart from what has been discussed, the important thing, remember, in such situations is the benefit for both, which is first the woman to remain undetectable and the husband to remain negative as long as we can. So aside from and remains virally suppressed, but we also have to, I think one part we often forget is to consistently ask about index testing to check out if she herself is not maybe engaging in other illicit sexual affairs because of those issues. There might be issues of reinfection. The sexual history is very, very important. And I think that's one aspect that I think maybe sometimes a couple, but right now we know that things are becoming diverse and we have to really think outside the box. And for those who are counseling, I think we really have to get as granular as possible. So first things first, to ensure the viral load is often checked, she remains suppressed to the numbers that we already discussed, but then also constantly ask about the sexual history. So, and then also to ensure that she doesn't have other risk factors that would affect the viral load in her body, such as ensuring that she's free of STIs. So we have to continue to testing her for STIs and obviously encourage the combination prevention PrEP for the husband. Eliminate also, it's all possible channels of entry. So I think those are the things I would think of, because other diseases such as the STI, cervical cancer, put to one at increased risk of either transmitting.
All right, thank you so much. We've taken note. Thank you very much for the feedback, Doc. Maybe we'll go to the next question. What other parameters should have been used to stop PrEP in this in the husband? We see that the only thing that was used here is a VL, wife's VL.
Okay, thank you. So viral load so far has been the most reliable parameter that we use for treatment, response to treatment. And as of now, we know that all facilities that provide ART are able to have access to viral load. And one thing that was quite impressive in a month, then even the follow-on viral load was also repeated within 6 months, which is very unusual in most sites where, because of turnaround time and other logistic challenges. So if you're able to consistently have this viral load repeat every 12 months and we maintain suppression for a prolonged period of time, definitely we just have to rely on viral load. We do not need to use any other parameter like CD4 or clinical monitoring. That does not, that is not part of our guideline. But one other thing we need to remember is that we look also at the partner's, sexual behavior. So from this presentation, the woman is HIV positive, although described as housewife, and the man is the one who moves around and works. If it can come from other partners that the man could have. So we need also to investigate in those lines. Does he work outside? Does he go far? Is it a migrant? Does it work in a different town? All those things might put him at an increased risk of acquiring HIV. So we need to put those into consideration. Thank you.
No, thank you so much, Doc, for that. You brought the issue of sexual behavior of the husband. That's a very important one. Then we go to the last question. How do we follow up the husband to ensure that he does not seroconvert? How do we follow the husband to ensure that doesn't, Dr. Bupe?
some of the points came out from what Dr. Mwamba said, which is the sexual history, and also just ensuring how well are we linking him to HIV negative or preventive services. I think we do well for positive clients, but then for the negative ones, we just say, congratulations, you're negative, send home. He also requires constant follow-up. So we need to regularly test. We also need, as Dr. Mwamba said, check his sexual background or activities or patterns, his environment, line of work. What other risk factors, in other words, could there be? Is he an injectable drug user? So I think we need to look more at environmental, social, economical factors surrounding him to ensure that he doesn't do that. And then also the basics, we go back to the basics. We're going for combination prevention. If he's on PrEP, that's good, but we know PrEP is not 100%, so we still encourage condom use. And we can also make sure that he's also circumcised. So I think these are all these other factors that we can think of. I don't know if there's anything else I've left out, Dr. Mwamba.
So nothing. You've actually paraphrased everything. Thank you, Dr.
Okay, thank you very much. Maybe from the feedback, we have a question from Sorezi General. Sorezi General, you can come through and please pose your question.
Thank you, Dr. Douglas. Dr. Musachi from Sorezi General Hospital. Just a reminder that there are some questions in the main fora in the chat that have not been addressed. Also, just to bring the question from the main chat, Dr. Paul Mwale from Ndola Teaching Hospital asked an interesting question where he says, what happens does U equals U apply in a case where in plasma or in serum it shows target not detectable, but in CSF the viral load is around 1,000. What do we do in such a situation?
Okay, very interesting question there, where we have viral load in CSF. Dr. Mwamba, would you be kind enough to respond?
Quickly on that one, we have less than a minute. U equals U only applies for sexual transmission. And we know where CSF is found, and it's quite far away from, from the genitalia. So we can only apply U equals U in when it comes to sexual transmission, and that was actually mentioned in the slide and the presentation by Dr. Natalie. Elsewhere, when it comes to other body fluid and other mode of transmission, it does not apply. I hope that was short and sufficient.
Okay. No, thank you very much, Mahatma Gandhi. And thank you very much, Dr. Bupe and Dr. Mwamba for the expert input that you've given to the facility and to the network at large. We really appreciate. I'll just recommend and request that we join back to the main.
Good afternoon. Welcome back, dear network. Are we all back? We can resume. So thank you so much for the breakout rooms, and I hope we had a very good discussions with our various experts. I'm aware that maybe Western Province, our expert, has struggled to join in during the presentation because of network. But all the same, I hope you had some fruitful discussions there. So I want to invite Southern Province just to give us a summary, then afterwards, then we'll have Dr. Vlahakis give a final remarks regarding today's session. Southern Province, are we on the call? Southern Province, is Dr. Jackson on the call? Or who? So Southern Province, we're not ready? Okay, so anyway, then let's go to Lusaka Province. Dr. Onoya, maybe you could just give just some key highlights from our discussions, and then Dr. Natalie will wrap it up.
Yeah, thank you so much, Dr. Zyambo. First of all, we appreciate Materomen for having presented this case. So the case presented showed that this woman was it's a case of a discordant couple. The man who is on ART has been on ART for more than a year. He's virally suppressed. The wife is pregnant, and the pregnancy is 28 weeks old, and she has been on PrEP for some time. They have got good adherence. So we agree that this is a case of U equals UI, because the husband who has been on ART for more than a year is virally suppressed. The viral load is undetectable. They have got good adherence, and there is no sexual transmitted infection. And where we didn't get it well, I don't know if we had more than one viral load result in the file, but we noted that the viral load was undetectable actually. Concerning the second question, because we only had the 2 questions, they wanted to know if the woman who is on PrEP can be discharged. So the room agreed that the woman cannot be discharged just for the reason that she's pregnant, and we know that U equals U has been proven to be effective in case of sexual transmission, but also research has proven that a few number of people, pregnant women, got infected during pregnancy, even when the other sexual partner was virally suppressed. So we are encouraging this woman to continue be on PrEP. We can't discharge her until she has delivered and she's done with the breastfeeding, unless if there's a comment from my other colleagues. But this is what we talked about. Thank you.
Great summary, Dr. Onoya, and I hope the network has picked up 1 or 2 things. Dr. Natalie, would you like to just give an overview and just close the session?
So I think, I did read the other cases as well that were presented, Western Province, Southern Province. So really good cases, and I hope you had in-depth discussions the same way we did with the Lusaka team. And just to thank the network for your active participation. It's been great, good questions, important questions. I think with PrEP and U equals U, it's always a contentious topic. So always available to support. Please don't hesitate to reach out. I did share my email address on the presentation as well. Just the important message to keep is maintain, for us to achieve U equals U, we have to have good adherence, make sure that the viral load is undetectable, make sure that in a discordant couple, the other partner is on PrEP as well, for as long as possible until the recipient of care is considered to be untransmissible. And follow something else that we need to follow through with is maintaining prevention interventions that complement each other. So making sure that we're using condoms adequately, along with PrEP, along with ART, because that is what is within our guidelines, and it is a key focus to pass on that message to recipients of care. Thank you so much. Thank you, Dr. Zyambo.
Thank you very much, Dr. Natalie. Dr. Bupe, we would like to hear from you as well. Are you able to make a comment?
Yes, good afternoon, everyone. And thank you, Dr. Natalie, for this lively discussion. And like you said, a contentious issue. You've raised all the points. And I think I just would like to emphasize the need for combination prevention, that no one method is enough, will suffice to achieve epidemic control or HIV negativity. So we really have to use all the armor we can. So I'm happy that you've brought out the PrEP and the use of the condoms. And I'd also like us to focus on other aspects such as STI management, because it can also affect one's chances of getting infected, and also looking at other methods as well, especially for the males, ensuring they're circumcised. And another part that we rarely ask about, which we discussed in our group, which is looking at the sexual activity and history of our clients. Yes, there are a couple, but are there any other illicit sexual activities that could affect their HIV transmission rate? So those are the things I just thought I should raise and emphasize on. Otherwise, thank you, Dr. Natalie, and well done for this topic.
Thank you very much, Dr. Musonda. And I want to thank Western Province, Southern Province, and Lusaka Province for the efforts in preparing these cases. As you know, ECHO is all about case-based learning, and without that, our learning experience is sort of minimized. And that being said, we look forward to seeing you next week when we have another interesting topic. And please do join us. We'll be talking about the registers, the Know Your Child Status Register, and just basically optimizing case finding in children. So we are inviting all of you to be part of that session. And thank you for joining us. Do have a wonderful day. We'll see you next time.